Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, topic of discussion is ocular toxoplasmosis. It's a case presentation. A 13-year-old girl with decreased vision for 3 days, mild pain and swelling in the right eye, came to our emergency clinic. Her vision was 2028.5 in 2020. It was not that much decreased, but blurring was more pronounced. On examination, right eye, the patient had granulomatous capies, anterior chamber reaction was +1, and on examination in posterior segment, there was vitritis, and focal areas of retinitis could be seen in a fluffy pattern over there. Left eye was normal. So this is the fundus photograph. I want you to please see that focal retinitis lesion is just under the fovea on the right side, and I don't know you can see the perivascular sheathing here or not in this slide. Let's see another slide. Yes, here perhaps you can also see the perivascular sheathing of the blood vessels, and there is also the retinitis, the fluffy pattern of the lesion in the macula. Now let's see the FFA. In FFA you can see here the lesion central and vascular sheathing and the leakage of the dye and hyperfluorescence. You can appreciate all these things in this patient, how the vessels are getting leaky and there's perivascular sheathing and this leakage of dye. All these things can very well be appreciated. This is another slide showing another phase of the dye. So basically these patients we did her workup, which was a required workup for the any uveitis patient, which is our protocol. We do it, BPD test, blood hole count, CBC, liver function test, renal profile, all these tests, and the IgG, IgM antibodies, all these things were done for this patient. But usually it is a very much clinical presentation. You can see over there. So we admitted the patient after doing investigations, all these things, and we did put this girl on the alternate therapy for the management of ocular toxoplasmosis. That is the combination of clindamycin plus cotrimoxazole. And usually we treat the patients for 6 weeks with this treatment regime. And after starting the antibiotics, after 3 days like this, we start the oral prednisolone, which is 1 milligram per kg body weight. That is also started. And after that, later on, our protocol is that this steroid therapy should stop. If the antibiotics have to go for 6 weeks, it should stop for 5 days before that. In a tapering fashion, it is discontinued. The purpose of saying this is that steroids are used under the umbrella and under the coverage of antibiotics. This is the message. The other therapy which we could have given is the classical triple therapy consisting of pyrimethamine, sulfadiazine, steroids, and folinic acid. But we did apply this, which I told you, the alternate therapy. OCT was done, it can be seen here, It was normal. We did not appreciate any macular edema or anything like this. It's right, and this is the left, normal. And after 10 days, we started appreciating the results. The lesion started decreasing in the size and in intensity, and the vitritis also starting decreasing. So the patient showed very good results, and this is the final image. You can see that it ultimately showed a scar, that lesion turned into a scar which is very near to the fovea, but her vision was not that much affected, and the vascular sheathing was also decreased, the vitritis was also decreased, and she was much better. Now the question arises about her pathophysiology, how it happens. We all know this toxoplasmosis because of Toxoplasma gondii, and the parasite exists in three forms: bradyzoids, stachyzoids, and oocysts. Cats, obviously, it is considered that oocysts are produced in the intestinal mucosa, and they are very resilient, and they are passed in the feces of the cats and contaminated food. So it can go with the contaminated food, and even by the ingestion of the meat which is infected. So these are different pathways which it enters into the human body. Even now, the polluted water is also considered a source of this. Initially, people were stressing about the congenital toxoplasmosis, but now the acquired one is given very much importance. So it can be bradyzoids, which develop after 4 to 5 days or after 1 week after the ingestion. This form develops, or it may be tachyzoids, which do direct penetration. It can infect different organs, your skeletal muscles, heart muscles, and even they can reach to the brain. So it's a tough disease to manage. It came to our clinic an emergency, and we managed it. So I decided to share these photographs, the FFA images, and our treatment regime. But we do it here, the alternate therapy and its coverage. I want to thank Professor Ahmed Abu Srar and my colleague Dr. Abdus Salam Diab, consultant medical retina and uveitis, who provided me this literature and these slides and helped me a lot in the preparation of this presentation. And thank you for your patience and attending this presentation. Thank you.